Let's come to the major topic of today, which is diastolic dysfunction. And there is actually a reason why we chose this topic. These are the guidelines which have been issued by the American Society of Echocardiography jointly with the European Association for Cardiovascular Imaging. After, I think, 2009, finally they revised the guidelines, and there's a lot of information inside. And I think there's a good reason why the guidelines have been changed, right?
Yeah, I think there was a lot of confusion, a lot of parameters, and they try to simplify it.
Right. I think this is the major reason that these guidelines have been changed. In certain areas, I would say relatively significantly. Let's see if it is really easier now. Of course, we're here to answer your questions. You have the possibility of actually asking questions. We'll try to come back to these questions, and you also have the guidelines in your little window on the side for download. So there's a handout section where you can download the guidelines. What we will try to do is we're going to try to go through, I would say, the 9 most important steps or features of these guidelines, right?
Yeah. I would say it's the 9 steps to heaven.
Okay, the 9 steps to heaven. But before we do this, we have a question for you. And the question is, what is your take on diastolic function at present? If you could just answer these questions to us, because we have the impression that there are a lot of people who are a little bit confused. To be honest, I'm a little bit confused too. And how would you assess, or how would you look at diastolic dysfunction? Which of these options would you choose? Would you say I hate it and I really struggle with the topic? Do you think it is probably important but I don't assess it? Do you think there are many situations where I'm uncertain? Do you routinely assess diastolic dysfunction and you say it's pretty easy? Or do you think you are the absolute king of diastolic dysfunction and this is just peanuts and easy? Of course, I'd be asking myself, why are you in this webinar then? But those are the options you have, and I want to see where you stand. Where do you stand?
I would like to say I'm the king, but definitely it's not true. I think I tend to confuse myself. That's the main issue on this. It's not that difficult as it looks.
Right. I think this is one of the problems we all have. It's a very difficult topic, and we'll go through the guidelines. And to be honest, when I read through the guidelines, I had to go through them 3 or 4 times to really understand it thoroughly. And I'm not sure if I really understood every and each point of it. But I guess together as a community, we should look at a way of, I would say, getting the most out of it at the end for our patients, right?
That's the key point. The question is whether you can help your patient or not.
Right.
And the way we will see how to get
so it's not all about impressing your friends,
no,
but it's about getting the most out. So we got the result here, and as expected, most of you say there are many situations where you're uncertain. So 74%, and this is, I would say, something that is ubiquitous in the entire world, which just clearly shows that there is a need to revise the guidelines and there is a need for more clarity. I hope we can do this.
That's definitely the aim of the presentation, and I'll welcome the 2% king of diastolic function. Hello.
Okay, so Martin, you said simplification is more or less the topic. Do you think the guidelines achieved that up front?
Partly. They partly achieved it. I think they gave us fewer parameters to guide us through the jungle of diastolic function. So yeah, partly they achieved this goal.
Yeah, I think this is also what I believe, but let's go through it. So that was the first part. Number 1, simplification. Number 2, basically the guidelines state that it is our intention to use a very clinical approach and to look for signs and hints for diastolic dysfunction, impaired relaxation, which can either be seen in the 2D image, for example, left ventricular hypertrophy, enlarged left atrium, maybe even bulging of the interatrial septum, maybe an expanded left atrial appendage, and of course, directly at looking at filling pressures. So the first important part is clinics first. Do you agree with this?
And don't forget the 2D image. That's also very important. Clinic and look on the 2D image. That's very important to assess it.
That's completely true. 2D image is very important. The third point, do you want to comment on that maybe about the issue of filling pressures?
Yeah, I think that's what the patient dyspnea is causing. That's relevant. Especially you have to separate the parameters what you are going to measure. Early diastolic pressures or late diastolic pressures. And you have to know what you're going to measure with each parameter to assess is there, for example, left atrial pressure enhancement. And then, because of the left atrial pressure, the patient has his dyspnea. So you have to know what you're going to measure.
Yeah, I think there was always a little bit of confusion in the past. People were asking, what is filling pressure? The truth is, it's a bag of parameters, and they are all not equal. Some parameters reflect early phase of diastole, others reflect late phase of diastole. And when we correlate these parameters with echo parameters, it has never really been stated which of these parameters we're really correlating with. And this is something you should keep in mind, and that is what the guidelines emphasize. So a lot more clarity here. Apple is not always an apple. There are different types of apples.
Yeah, exactly.
Right. The fourth point, let me go back to these two curves just to exemplify that. You see, this is the pressure curves during diastole in the left atrium and the left ventricle. You see, obviously they correlate strongly, but not always to the full extent. And you will always have different pressures in different phases of diastole, which do obviously account for some of the differences that we have when we compare parameters, right?
I think that's the key point. You can see, for example, early diastole, for example, it's the E wave, and late diastole, and different measurements for different phases of diastole. And you have to know what you're going to measure.
Exactly. The fourth very important part is that, and you mentioned that, there are 4 parameters that you should basically use to assess diastolic function in patients with normal ejection fraction. Martin, can you run us through these 4 parameters?
Yeah, of course. First of all, you have to measure E prime, lateral and medial, and there's new cutoff values. You can see there, lateral it's 10 and medial it's 7. After that,
wait 1 second before you go on. A question. You see lateral and medial. What is the advantage of one over the other, and which one should you measure now?
There is no really advantage. There are different studies, but you should average it. That's the key message. You have to average it and then average E to E prime. That's the key message.
And why is the lateral E wave usually higher?
Yeah, because the lateral wall, it's not that fixed in the annulus fibrosus. You know, septal, the heart is good fixed and hasn't that space to move.
Right.
In lateral, there's much more displacement because it's a free wall. Okay. So therefore, lateral, every time you measure lateral, it should be higher, except in certain clinical situations.
Right. So this is an important thing to note, but there's another intriguing thing, and this is maybe a little bit of a criticism. They call the E prime one parameter.
Yeah, it's one parameter, yeah. Because otherwise it would be 5 parameters. I would guess that's more easy, because we'll see afterwards, if you have 5 parameters, there's always 3 to 2.
Okay, so we'll have a majority vote.
Yeah, and so we get often to the 50-50 situation.
Yeah, so, but keep this in mind, the guidelines state that this is one parameter, lateral medial. Okay, good. The next parameter.
That's what I told you. You have to average E over E prime, and you have to look on the ratio. And therefore, there's a cutoff value for 14, and it shouldn't be above.
Right. And the authors do account for the fact that some centers don't measure both. They only measure one. And so they do also give cutoff values for the lateral and the septal. But I guess the better way to do it is to use the average, I guess, right?
Of course, it's better. Sometimes maybe you don't get both if there are bad echo conditions. Mm-hmm. Then the guidelines say you can use only one of that. That's also a reason why it's separated. But usually you can measure both, and then you should average it. It's more accurate. Okay,
good point here. The third parameter?
Yeah, it's the left atrial index. It's very important to index it to the body surface area. And there's a specific cutoff with 34 milliliters per square meter body surface area. And that's because of some studies, they show us that above this limit, mortality increases.
Right.
And that's the reason for that cutoff.
So this value has been looked at, and this is kind of the range where, or the value where the increase in mortality starts. So that's why they chose it. And the reason why the left atrium is so important is because obviously if you have chronic pressure overload in the left atrium will obviously expand. But keep in mind that there are many other reasons why the left atrium could be dilated.
For example, atrial fibrillation. You have a dilated left atrium, but maybe without elevated filling pressures. Atrial fibrillation in the whole is a challenging condition.
Right, that's true. So this would be one. Microregurgitation would be another. And then there's some certain variations. Some people just seem to have an atrium which is larger. Volume plays a role. So keep in mind that you have to know the clinical condition as well to understand why the left atrium is enlarged. And there could also be situations where filling pressures are high and the left atrium is small, especially at the beginning.
And the guidelines definitely tell us not to use diameters anymore. Stop it, use volumes. That's a key message of the guideline.
That's absolutely right. And I can only agree 100%. I've stated that in many of my lectures. The reason is that a simple parameter such as the diameter does not reflect the true geometry of the left atrium. And it's not much more time consuming to contour the left atrium. It's quite easy, right?
Much more accurate.
Yeah.
Yeah, the last parameter, it's the TR velocity, of course. You can measure pulmonary systolic pressure directly, and there's a cutoff level for 2.8 meters per second. Above that, also this criterion is fulfilled.
Right.
And then out of these 4 criteria, we should make a diagnosis.
But let me come back to the TR velocity. I think many of you are not aware that this is also an indicator of elevated filling pressures. Why is that so? Let's go back to the physiology. Now you've got high filling pressures in the left atrium, and they will automatically translate via the pulmonary circulation to the right heart and cause pulmonary hypertension. Both pulmonary hypertension and left atrial filling pressures are very, very good correlates of symptoms. They cause dyspnea. That's the substrate of dyspnea. So if you have high filling pressures, in most cases you will also have pulmonary hypertension. However, it's not true vice versa. You can have patients who have very high pulmonary pressure but normal filling pressures. When?
Especially if some pulmonary disease, maybe bronchial or pulmonary arterial disease.
Mm-hmm. So in other words, if you have a patient who has pulmonary vascular disease, if he has precapillary pulmonary hypertension, that would be one of the causes of this. So keep this in mind. But you said correctly, the cutoff value is 2.8, right?
Yeah, that's the cutoff. If this criteria is fulfilled, yeah, you have the possibility with the 4 parameters we just told you to make the diagnosis whether there is elevated filling pressures or not, diastolic dysfunction or not in subjects with normal ejection fraction.
Yeah. Maybe a little bit of a criticism on my side here is that this is maybe a too rigid cutoff value, considering that the normal values are very age dependent. If you have a young individual with maybe 2.2 would be even normal, and pulmonary velocity normal values increase with age.
That brings us to the point that all of these parameters are age dependent. Keep that in mind.
Right. Number 5. So now we've got these parameters, and the rule number 5 tells us that we should count how many of these parameters are positive or negative. And if we see that more than half of these parameters are above the normal values, then it is quite clear that the patient has diastolic dysfunction. So very straightforward and easy. In other words, we have a way of looking at all the parameters. If 3 are positive, 1 is negative, then he's got diastolic dysfunction. But that still means we have an uncertainty if half are positive and half are negative. What do we do then?
Then you have to look on other parameters. Or you can write in your report, and that's maybe the better way. There are some situations where we are uncertain. I'm uncertain, I think Thomas is uncertain, and maybe you will be uncertain. The truth is to write it down. It's not in every patient you can make a correct diagnosis. That's a very, very important point, and the guidelines emphasize us to do that.
Yeah.
Yeah.
I think so. You know, all of you who put in the report, I don't know, you're not doing wrong. That's the way it is. We are just not good enough in many situations to really know. We have to be fair, and I think we discussed that before the webinar. I think what many people seem to do is they kind of, push the measurements so that they have a clear decision as to whether or not have a diastolic dysfunction. This is probably not the best way to do it. Just be honest and say, okay, 2 are positive, 2 are negative, forget it. And if you do want to do more parameters, you're welcome to do so. If you, we'll come back to that later. Let's stop here, I think.
I think you are not a bad echocardiographer because you are not able to decide. That's the truth, and then write it down in your report. It's very important.
So this is the scheme that has been proposed in patients with normal ejection fraction. Again, whether or not you think that diastolic function is present, you look at these parameters, and if you have more than half which are positive, then you have normal, let me put this, normal diastolic function. If you have less than 50, which are positive, normal diastolic function, and if you have more, then it is classic diastolic dysfunction, and this is the intermediate group where we simply do not know. Just as a reminder, you can always ask questions. You have the possibility of writing a question into your chat box, and we'll be happy to answer them. I think you should actually take this opportunity. We have an expert here, and we'll try to, of course, give you the best answer we can. Good. So, but this is not all that is in the guidelines. But before we talk more about the guidelines, I want to now come to an example or to a case where we look at exactly what has been stated in the guidelines and try to apply it to this individual patient. So this is a patient who was 72 years old, and he had exertional dyspnea and fatigue, and was brought to us for evaluation. We performed a pulmonary function test, and that was okay. So he had no pulmonary disease, at least no COPD, and then we performed the echo. Martin, it's your take.
Okay, so you can see he has good ejection fraction, and there is a concentric hypertrophy of the left ventricle. And the left atrium, for me, it seems normal volume. So maybe that's an HFpEF patient. We'll see.
So you see that there's a lot of information already in the 2D image, and focus on it specifically with respect to diastolic function. Some things that maybe I would like to also emphasize, and Martin said it, is left ventricular hypertrophy. Now, if you have a patient who has a septum of 16, 17 millimeters, do you think that he has diastolic dysfunction? Yes or no?
Yeah, I think that's what I meant by look on the 2D image. It really helps you. Right. Really helps you.
So basically, you can almost stop there. You will not find a patient with such significant LVH who does not have diastolic dysfunction. In athletes maybe, but athletes usually don't have more than 14, 15 millimeters. The other parameter is the size. You already mentioned that. One other thing I would take a look at is the interatrial septum. If you have bulging of the interatrial septum to the right, it would also indicate high filling pressures. And then there's one other thing I think I'll show you in the next image, in the image after that. But maybe I can hand it over.
No wall motion abnormality. It seemed that the walls are good opening walls. We'll see the color flow, but I think the walls are normal, so that's not the problem of this patient.
Yeah, see they open, so it doesn't seem to be a valvular problem, and I can assure you no significant AR, MR, and so forth and so on. And this is the two-chamber view, which shows about the same thing. I was hoping I would show it here, but one thing that you should be aware of, that the left atrial appendage, which is not visible in this patient, but which would be seen somewhere here, sometimes can also indicate elevated filling pressures, because you would see large left atrial appendages, expanded left atrial appendages in such patients.
But it's a clear statement to exclude it in the measurement. So if you measure the size of the left atrium, you have to exclude left atrial appendage and, of course, pulmonary veins.
Okay, so here are the measurements now. The left atrial size was 46 milliliters. If you index that, you would get 24 millimeters The cutoff value is normal. Okay, so left atrial is negative. And now to the tissue Doppler.
You can see decreased E' velocities, both septal and lateral. Interesting, lateral, it's even less than septal. I wouldn't expect it the other way around. But in this case, you fulfill this criteria, it's below the cutoff level.
Okay, so that's clear. You could actually stop if you do the medial. You don't need to do the septal anymore, right? The lateral anymore, right?
No, we can stop.
So again, we have a positive, a negative parameter, and then we look at the E to E prime.
And it's above the cutoff level of 14, so it's also a positive parameter. So after that, we could say it's elevated, it's a diastolic dysfunction. And
you would not even need this here, right?
Yeah, that's the key point. The key point of the guideline is that in patients with normal ejection fraction, you can stop at the point you have measured the 4 parameters and decided whether there's elevated filling pressures or diastolic dysfunction or not, and you don't have to confuse yourself with the inflow pattern. That's a key message for patients with normal ejection fraction. That's important. Okay,
so we've got diastolic dysfunction here, and this would the diagnosis here be now? Normal ejection fraction?
Normal ejection fraction and diastolic dysfunction. That's the diagnosis, but maybe not the diagnosis of the patient.
Right.
We'll see.
Classically you would say this is a HFpEF patient, heart failure with preserved ejection fraction. All the criteria fulfilled. But again, I think it's so important to take a closer look at the image, and maybe you want to comment on that.
Yeah, that's what I mean. Look on the 2D image. You can see pericardial effusion, and that's the point where you have to start to think, why has this patient pericardial effusion? And then don't try to press this patient in a HFpEF to a HFpEF patient. Maybe it's something else, and you can do maybe some other parameters to get the diagnosis.
Right, and this is what we did. We used a Speckle Tracking tracing or analysis, and what you can very nicely see is that actually Speckle Tracking is not normal. You have an inhomogeneous reduction of the global longitudinal peak systolic strain of 13.3. You remember the normal value is somewhere between 17, 18, and that's definitely below. So this means the patient actually has subclinical systolic dysfunction. Yeah. According to the new HFpEF guidelines, this would still be a HFpEF, right?
Yeah. The funny thing is that the global longitudinal strain, peak systolic strain, it's new in the guidelines. You can use a systolic parameter to decide about diastolic dysfunction. That's totally new, and it makes clear how tightly they are coupled, systolic and diastolic dysfunction.
We're getting some questions in here. Give me a few seconds. I want to conclude this one case here before we come to the questions, because I think this is very interesting. Because what do you think this patient really had? Well,
amyloidosis.
He had amyloidosis. Now, many of you are going to say, well, this is not a classic case of amyloidosis. You would have speckled appearance, and you'd have, maybe thicker myocardium and thickened valves. But there's a clear reason why. This is still an amyloidosis.
It has to start at some point. So usually you'll see the end-stage patient, and then it's restrictive filling and everything is fulfilled. But in the beginning, it's a patient like this, hypertrophic, maybe diastolic dysfunction, and yeah, that's it. And maybe a lot of you maybe have guessed that the strain image will show apical sparing. Typical episode. You can see it here, but it's not that typical. In my opinion, in my experience, that's difficult. You can see apical sparing patterns not only in amyloidosis. I know it's in the guidelines, but it's a pitfall maybe.
I think Martin is completely true. Apical sparing has been proposed as a typical sign specific to amyloidosis, which it is not. You can see that in hypertensive heart patients. We can see it in aortic stenosis. But the key point here is, as Martin mentioned, with the help of diastole, and specifically with Speckle Tracking, we're able to detect a disease at a relatively early stage. Now, this can really impact the therapy of the patient, because frequently we see patients who are end-stage heart failure patients with amyloidosis, and with these parameters, it is possible to detect. And I think that is one of the strengths of going more into detail, looking into diastolic function, even though one might argue, who needs all these parameters? Do a speckle tracking and you will notice that something is unclear.
We'll see what the future will bring. Yeah. But another key point is that in this case, you will help the patient because you get the diagnosis amyloidosis and not because you can estimate the filling pressures.
Right. Let me answer some of the questions. The first question was, what do you do if you have a fusion of E and A wave and you can't get it apart with Valsalva maneuvers? Well, it's very difficult because actually in such a situation you cannot use the E to A ratio. However, you can still use the E to E prime. And sometimes you can actually differentiate the E and the A wave if you do a tissue Doppler study. So sometimes it's easier to see the E prime than it actually is to see the separation of the E and the A wave. Still, in most patients, you will be able to actually separate the two if you do some kind of a vagal maneuver. However, watch out. I've recently had a patient where I did a carotid massage and then I had a pause of something like 7 seconds on the echocardiogram. It's kind of a scary situation, but nevertheless, I think even in these situations, you can get to the information, and often you have to wonder, will it really give me additional knowledge? Honestly, the patient is probably dyspneic. He has tachycardia, a high heart rate, that's why you have the fusion. Or maybe he has an AV block, first degree, that's why you have the fusion. And in reality, is it really going to change much? In such a situation, if I'm not able to really assess diastolic function, I'll just put I can't assess it. Sorry, come back with the patient when he has a normal heart rate, and we'll take a look at it then. Good. Then the second question by Ridwan, he says, in a patient with significant mitral regurgitation, it is difficult to assess the E to A ratio. How do you assess diastolic function in such a patient? Martin.
Definitely not by using E to A ratio. It's a difficult condition in whole. All the parameters are not validated for mitral regurgitation for significant MR, and therefore there are some studies made with isobarometric relaxation times, for example. It's not that easy.
I must also question the value, because remember, if you have significant mitral regurgitation, the patient always have increased filling pressures because you've got regurgitation.
And is it the problem of the patient? I don't think so. If it's significant and the patient has symptoms, you know the guidelines. Maybe you should operate him or reconstruct it or something like that. It's maybe not the key question.
Right. There's been people who say that patients only have significant mitral regurgitation if the E wave is very high. Have you heard that, or what is your take on this?
I think it depends on the fluid status.
Right. So I think so too. You do see it frequently.
Also pitfall.
Yeah.
Could be a pitfall. It's right. Yeah. E wave increases, but it's not that clear. And maybe you treated the patient with diuretics and everything will change. Maybe the MR seems moderate after therapy.
Just to our crew here, can you go back to the first question? Scroll a little back because I need to see the question once more. Okay. Greg says, once you have made the diagnosis of diastolic dysfunction, what can you follow on echo to decide whether they have had sufficient diuresis or whether they benefit from more diuretics? A very good question. Greg, can you hold this question for a second, because we're going to go to a case where I think I can comment on that on a specific example. And then there was another question asking whether or not this also applies to patients with reduced ejection fraction. Well, according to the guidelines, you should take a little different approach on patients who have reduced ejection fraction. We'll come to that again. So I see many questions are coming in. Let me go to the next point, which I think is very important because it's going to answer maybe some of the questions that you have. So estimating the severity of diastolic function with filling pressure. So that is the second or the next big issue that has been looked at in the guidelines. It's the question of how do you grade diastolic dysfunction? Remember the scheme of normal and impaired relaxation, pseudonormal. Does that still hold true?
No, that's one of the major difference between the last guidelines and this guidelines, that you should look at the inflow only in patients with reduced ejection fraction. With patients with normal ejection fraction, you can use the parameters we showed you before, and you don't have to confuse yourself with the inflow pattern. That's key message. For normal ejection fraction, you don't have to create it by the mitral inflow.
Right, and the term of pseudonormal is gone, right?
No, it's gone, yeah. It's grade 1, yeah, it's grade 2.
It's grade.
Yeah, so it's grade 2 is pseudonormal. It's gone, and maybe it's not that important anymore. We'll see.
Okay, so this is the scheme that is now in the guidelines. Simple. Is this a simple scheme?
Yeah, not on the first view.
Yeah, so I guess it looks very confusing. Finally, we've kind of got accustomed to one scheme, and now you've got this flow chart, which looks very complex. I think it's not as complex as you might think it is. We'll walk you through it. We'll show you some examples, and you'll see that it's not so much different than what we were using before, and there's a lot of rationale behind it. Still, what now is stated as a very important point is that if you have a patient who has an E to A ratio of less than 0.8 and an A wave, which is less than 0.5 meters per second, then you have grade 1. This is what we always called impaired relaxation or grade 1 diastolic dysfunction, right? So this is relatively easy to understand, but there's one small difference to the old guidelines.
Yeah, it's the in the old guidelines it was 1. The cutoff level was 1, and that led to a lot of confusion because it's age dependent, and maybe 0.8 it's normal for my grandmother, but maybe not for me. And so they cut it down to 0.8, and it seems to be more accurate.
Right. I think also this is a very good way, because remember, frequently you had E to A ratios which were E and A almost the same, and sometimes it would vary according to respiration, and you would not know where you should go. Now they clearly state, first of all, you have to have a definite difference between the E and the A wave, meaning the A wave is higher than the E wave, and also that the E wave should not be too high. So they're kind of now more closely defining what is called grade 1 diastolic dysfunction.
But if it's that way, everything is clear. That's the simple way to look at it.
Okay, right. But what if this is not the case? Now here is the second point of this flow chart, which says, okay, what if the E to A ratio is below 0.8, but the E wave is more than 0.5, or if you have an E to A ratio which is somewhere between 0.8 and 2. What do you do then?
Then you can take the measurements you have heard before, LA volume, TR velocity, and averaged EOA prime. So from that point on, it's quite similar to the first part we told you. So that's not, maybe it's not that difficult. You just have to separate 3 groups by the inflow pattern and then go ahead with the thing you know.
Okay, so I created a flow chart from the flow chart, which abbreviates this. Again, doesn't look very simple, but the idea again is to have, when you have 3 parameters, take a look at how many of these parameters are positive, how many are negative. So if 2 or more are negative, then it falls back into a grade 1 form of diastolic dysfunction. So you could theoretically have a patient who has an E to A ratio of maybe 1.4, for example, an E wave which is actually higher than the A wave, and it would still fit into the category of grade 1 diastolic dysfunction. This is new. And then if you have 2 or more parameters which are positive, then it would be classic grade 2 with definite or with highly likely elevated filling pressures. And if you only have 2 parameters available, for example, if you can measure the TR velocity and you have LA volume which is over and maybe the E to E prime which is under, then you're in a situation where you are, again, undecisive.
And never use one single parameter to assess whether the filling pressures are high or low. The guidelines definitely guide us not to do that. That's also very important. One single parameter, it's less, it's too less.
Right. Good. Confused? I think there's a lot of information in this. of course, many things are new. I would now like to ask you a question. And my question to you is, how do you judge the new guidelines up to now? How do you see this information? Do you say this is really easy to understand now? Do you say it's a bit challenging, but still very clear? Is this difficult, but you say, okay, you still prefer the old parameters? Are you lost and do you want to go back to the old parameters? Or do you say, oh my God, this is terrible, I don't want to use this? I'll give you a few seconds to give us your take on this. Coming back to the question of complexity or not complex, how would you see this?
I think it's not that complex as it looks on a first view, especially if you decide for patients with reduced ejection fraction, you can make 3 groups, and then you can go ahead with the average EE prime, LA volume, and TR velocity. So it's pretty the same, just the inflow pattern over all this.
Okay.
It's maybe not that difficult, but
let's take a chance while people are voting to answer a question. How can we undertake Valsalva maneuver if the patient is mechanically ventilated on the ICU? Can an inspiratory pause, as we use it in respiratory mechanical assessment, be considered an artificial Valsalva maneuver? What would you say? It's a difficult question.
I would say there are definitely no data for that. So I cannot emphasize it.
You know, what you can use is you can use a PEEP maneuver. However, we know, for example, that under ventilated patients, many of the parameters we use in conventional echo are completely different. If we know, for example, that the IVC size is inversely related to the respiratory phase, and similar probably is also true for diastolic dysfunction, that the whole situation of the patient being ventilated confuses many of these things. To be honest, at this point we're struggling to look at the normal patient to understand diastolic function. I think we're so far away from understanding all of the influences that patients have who are mechanically ventilated, because it might not only be the mechanical ventilation, but it also may be the underlying problem of the patient that affects all of these parameters. So my question would be, why would I want to look at diastolic function in a mechanically ventilated patients, and how secure can I be that this information that I'm obtaining is really of clinical value on which I can base some form of therapy? I guess the most important question will be, what is the volume status of the patient? And I think there are other parameters that would probably help me more. That would be my take, I think.
Yeah, mine too. I think it's don't confuse yourself by filling pressures in a ventilated patient. Maybe his problem is not the filling pressure.
Okay, so now we've got the answers, and most are between B and C. So congratulations to the guidelines committee. They say it's a bit challenging, but it's still very clear. Some, however, do say this is difficult, but I still better use the old guidelines. What we will try to do in the next months, we're going to sit down and look for a way that will make it, I would say, not even simpler, but to extract this information, the guidelines, and make a so-called easy peasy handsheet method of using diastolic dysfunction, which works in, I would say, 90% of patients. I think this will be our challenge, because my take on this is that we need to make it simple, otherwise people will not use it. And I think that most of the parameters that, well, let's put it this way, in 90% of patients you can probably assess diastolic dysfunction with 2 or 3 very simple parameters or with simple information. And many of these exceptions to the rules only pertain to 5 or 3% maybe of the patient population. And therefore, I think it just looks more complicated than it really is. Okay, we need to go on. Let's take a look at an example. This is a patient with dyspnea.
Yeah, it's good ventricular, left ventricular ejection fraction. It's again hypertrophic. This time I will say the left atrium, maybe it's enlarged. And yes, maybe it's low volume in the left ventricle. That's
right. Two-chamber view, no wall motion abnormalities.
Yeah, walls looking good.
No mitral regurgitation. Now, E to A.
Yeah, now it's not that clear. E to A, it's 1.5. I know, it's sorry, it's the E wave. It's
1.5 and O is 0.9. So if you look at the pattern, it could be a normal, or as we would previously call it, a pseudonormal pattern.
Yeah.
Right? In this case, we need more parameters, but we'll now use the scheme that was proposed and see how we can use it. So this would basically mean that we've got an E to A ratio of 1.7, and which would show us that we're in this category here. So it's not impaired relaxation. So we have to now look at more parameters, and we'll do this by looking at the E to E prime. And here we get an E of 0.05 and an E to E ratio of 30.
So yeah, if this criteria is fulfilled, it's definitely not normal.
Right, so we again have a positive value right up here. So one criteria is positive. Now, pulmonary pressure, we assess that, 3.6.
It's above the cutoff level, so at this point, we can stop.
Positive, because we have two parameters. Remember, if two parameters are positive, then we are already in grade 2 diastolic dysfunction. Here we go. So that's as simple as it is. Okay, we've got this intermediate phase. We look at these two parameters, positive, stop here. You don't even have to look at the LA volume, which I think was also maybe fulfilled in this patient. So that's how you would apply this scheme. However, you have to be cautious because it is not recommended in atrial fibrillation, in significant mitral valve disease. What is MAC?
It's the calcification of the mitral annulus, the mitral annulus calcification, and yeah, we have to say that from moderate mitral annulus calcification on, there are also no data for measurement of E prime. So I think most of us are not aware of this.
Right. Then left ventricular assist device, and then they also say in ventricular pacing. I usually did assess diastolic function in these patients, but the guidelines say no. I'm not aware if there's any data out there, but maybe they're just not 100% sure that it can be applied. But I think this point very nicely also fits to the question that Teresa is asking, and she wants to know, may I ask for tips how to evaluate diastolic dysfunction in atrial fibrillation? Very good question, because many patients do have atrial fibrillation. What do we do?
Yeah, that's also very clear in the new guidelines. There's just one robust parameter, and that's the E over E prime measured in septal annula. So that seems to be robust, and you can use it also in atrial fibrillation, but be careful, you have to measure 10 beats or maybe 3 representative beats. You know, they should be in a range of 20 to maximum 30% of the average heart rate. Then you can use E over E prime measurement septal. Then it works.
Very good point. Obviously, you have to average that both for the E wave and for the tissue Doppler signal. Right?
Yeah. It's very important.
So, and what about the deceleration time?
Yeah, it's a little bit confusing. Deceleration time, there are some studies that emphasize to do it. In the guidelines, it's not that emphasizing because it's challenging. Deceleration time could cause more confusion in my experience, maybe, than bring clearance in it.
Yeah, because especially if you have a high E wave, the deceleration time is usually a little bit longer. Yeah.
Longer than the cutoff, and then you're confused. So try to use simple approaches. That's key message.
Okay. And then what else is in the guidelines, and I find this as a very interesting issue, they say that use Speckle tracking to assess subclinical systolic dysfunction. Now, even though this is a guideline on diastolic dysfunction, they're using Speckle tracking, and I think it does make sense because, after all, we want to know if maybe left ventricular function is impaired. But again, brings me to the whole issue of what is HFpEF and what is, now we've got this new entity called
HFmREF.
HFmREF.
So it's in between. So I even don't know. I think they stick together. And in my opinion, we'll see in the future that there's a lot of subclinical systolic problems in the HFpEF patients.
I think that there needs to be a little bit more clarity, because there's even some inhomogeneous or incongruencies between the guidelines on HFpEF and the guidelines on diastolic dysfunction. Obviously, there's two different committees here. Still, I think one has to, but this is my very personal feeling, revise the whole idea of heart failure with normal ejection fraction, which basically implies, or that's what it used to do, that there's a diastolic dysfunction. And we're now realizing to a greater extent that this is not the case, that patients only have a normal ejection fraction, but there is subclinical systolic dysfunction. So why don't we just call it heart failure with subclinical or grade 1 systolic dysfunction? It would make much more sense and also much more clarity, and would stop all this confusion. But I guess we'll just have to wait what comes out of this. Let me take the time to answer a question from Rutian, who said, could you also show how to assess right ventricular diastolic dysfunction? This is something which is even less clear, and there are studies and publications. I'm not aware of any guidelines here. Are you? Or?
No, there aren't guidelines. It's too less clinical data, and it seems to me to be more difficult, even more difficult than left ventricular. So there are no guidelines.
Right.
And
I mean, remember that the right heart and the annulus and all the parameters are much more prone to variations in respiration. And this means that the measurements are probably even more, I would say, fluctuating. And even though I'm aware that there is something like right ventricular diastolic dysfunction, I don't really assess it in a routine sense, and to be honest, I don't have any experience, and I'm not aware of any large studies or recommendations at this point. Yeah.
Sorry.
Another question by Ridwan. If you have a patient with both pulmonary hypertension and diastolic dysfunction, how do you detect that the diastolic function is causing the elevated arterial pressure if there is another contributing cause, for example, type 1 or type 3 pulmonary hypertension? Can you estimate left atrial filling pressure with a prediction equation and subtract from estimating pulmonary arterial pressure to create a transpulmonary pressure? Good question.
Good question. There's an answer in the guidelines. In these situations, you should make a CAF.
Yeah. I think that if you look at the guidelines on pulmonary hypertension, it's clearly stated that if you have pulmonary hypertension, to clearly say if it is pre or post capillary and to validate the pulmonary hypertension, you need a right heart catheter. One thing, however, that I do look at in echo is, if I have a patient who has pulmonary hypertension, I would also look at the left heart and look at filling pressures. If the filling pressures are normal there, and you have pulmonary hypertension, it would speak in favor of pre-capillary pulmonary hypertension, versus if you have high filling pressures and you have pulmonary hypertension. The classic example would be, for example, a patient who has a disease such as cardiomyopathy or decompensated aortic stenosis or mitral stenosis. So I try to, of course, exclude a left heart disease. And if this is the case, and if filling pressures are normal, despite pulmonary hypertension, then I would probably think that it is pre-capillary pulmonary hypertension. And in this case, you obviously need to go to a cath study to confirm that.
And if there is left ventricular disease, you have to think about it, because coincidence is not that high. So what should it be? The coincidence is very low for having both left ventricular dysfunction and as a pre-capillary pulmonary hypertension. So that's unlikely.
Right. That's true. That's true. One more question before we go on with the presentation. Rudian says, how is everything going with your Speckle Tracking course? Good question. We're working very hard on this. This is, for me, one of the most important topics in echocardiography. And at the moment, I'm still collecting a lot of material. And we are working together with special vendors to give you very good insights in the technology of it. The next course that we're probably going to post online is going to be the transesophageal echo course. Hopefully this is going to come end of September, beginning of October. And then after that, the next course will definitely be Speckle Tracking. We hope to have it ready before Christmas. And maybe this is going to be my little Christmas present to you. Okay, now let's go on with the next point, and coming back to the patient that we showed you previously, where we came to the conclusion that there's definitely grade 2 diastolic dysfunction. And now if we take a look at a speckle tracking image,
it's impaired systolic function as well.
So again, on the surface it's a HFpEF. You can still grade it as a HFpEF, but beautiful example of a patient again who has, I would say, subclinical systolic dysfunction and therefore elevated filling pressures.
And again, it's a bit funny because the guidelines give us a systolic parameter to differentiate in between the diastolic dysfunction. Even there are studies of diastolic strain. This is the best parameter, so the systolic seems to be most robust.
Okay. So can you tell we're going more and more towards speckle tracking? Okay. So this is going to be obviously a very important topic also in diastolic dysfunction. Now let's come to the last and 9th point. In patients with reduced ejection fraction, that's going to answer some of the questions that you have. What are you supposed to actually look at the transmitral inflow pattern, and that is usually sufficient to identify patients with increased filling pressures. So can you comment on that maybe?
Yeah, it's the same as before. As long as it's typical, for example, E to A ratio more than 2, so everything is clear, it's restriction. And then you don't have to fulfill other parameters.
Right.
So yeah, in that case, it's clear.
So it's a lot easier. Remember, in the previous guidelines, they would say, well, you cannot use E to E prime in the setting of reduced ejection fraction. And the guidelines now say you don't have to anyway, because everything is clear if you just do the mitral inflow signal. So this is, again, going towards, don't measure everything, only measure the things that you need. And with the mitral inflow signal, most things will be clear. And they also say that deceleration time of mitral E velocity in sinus rhythm is also an important predictor of outcome. So you can do that as well. A steep curve would mean that you have elevated filling pressures. What is the cutoff value?
Yeah, it's 180 for atrial fibrillation, maybe 160. There are different studies and different data, but that's a gray zone, a little gray zone.
Okay. I do want to mention that we have to understand why patients get an E wave and what affects the A wave. And this is very important because even the guidelines say that to really assess patients with diastolic dysfunction, you always have to understand what these parameters really reflect. And if you have a thorough physiologic understanding, sometimes you don't need to go all these flow charts. It will just mathematically be understandable to you. And with respect to the E and the A wave, what is so important is that the E and the A wave are affected by the volume within the left atrium, both in early and in late diastole. If you have a patient who contracts or fills a lot of blood in the early diastole, then not much blood is left for the atrium to kick in. That's why you'll have a large E wave and a small A wave. Just understand this. The other thing is that left ventricular suction is an important factor. In other words, especially in young individuals, there's a phenomenon that kind of pulls in a lot of blood, causing a high E wave. Then you would have the pressure difference between the left atrium and the left ventricle. That obviously plays an important role. This stiffness of the left ventricle, very important factor. That's the compliance. If the ventricle is very, very thick and hypertrophic cardiomyopathy or hypertensive heart disease, obviously, you're going to have a resistance to flow. And then finally, it's the contractile function of the left atrium, which is so important. Maybe, Martin, you can give us an example of where that might play a role?
For example, in atrial fibrillation. The left atrium isn't contracting anymore. And that's the reason, maybe it's a part of the reason why the patient has dyspnea, because he's losing the contraction of the left atrium. Therefore, there's no A wave, as everybody knows. And therefore, it's E over A prime, as I mentioned, the only robust parameter.
And what about after cardioversion?
Yeah, then it comes to an atrial stunning. Directly after cardioversion, there's also no or nearly no A wave. So don't be confused. A few days afterwards, the A wave is back. And in this case, you can use deceleration time with a cutoff of 160 maybe. So that's one of the few clinical situations where the deceleration time is maybe helpful.
Okay. One last case. This just to exemplify how one could use these new guidelines. A relatively young patient who had a very large LAD infarct. You can see a huge wall motion abnormality. The entire septum apex is akinetic, and so is the anterior wall right here. And the patient was treated for infarct, and he went back home, and he didn't see the doctor for 4 or 5 years until he came to our lab with dyspnea. And the guy was really symptomatic. You know, he had rouse over the lungs, so it was clear that he had dyspnea. And now we're going to assess diastolic dysfunction and look at his filling pressures. Martin, do you think he has elevated filling pressures?
I'm pretty sure. Everything else would be surprisingly.
Yeah.
So maybe you don't need anything to know that.
Yeah, I think that's just one of these examples which show us that, you know, you have to put everything into perspective. I mean, if the patient has this ventricle, and if the patient has dyspnea, and I mean, look at this, the atrium is enlarged. You don't need to go any further. In reality, everything is quite clear. But just to exemplify this, we'll perform a Doppler study, and here is the pattern.
I can see it's very low A wave.
The A wave is probably best seen here. It's very low. So the ratio is
over 2, and it's
yeah.
restriction, and everything is clear. So you can do it. It will fit, but you know, maybe you can lower the filling pressures in this patient by diuretics, but nevertheless, he has diastolic dysfunction,
right.
And this will remain.
So I'm coming back to one of the questions. I can't remember who asked it, but way at the beginning, the question was, well, how do you follow these patients up, and how can you use this information? I think this is probably one of the best or most important, I would say, indications for looking at these patterns, because now you've got this pattern, and then you're going to treat them with diuretics, and you have a very nice way of looking at the effects, because if you're lucky and if the patient is not too bad off, you can reverse the signal to maybe even impaired relaxation pattern, a grade 1 diastolic function. And this kind of can guide your therapy. However, if you come to a point where I would say, let's say the E wave is then very small and the A wave is very high, then that sometimes can be an indicator that you should stop your diuretic treatment simply because you're coming towards hypovolemia. So this is where you should stop. Of course, this is not the only parameter you use, but you're going to look at the clinics of the patient and see if he has signs of execosis and if the patient is doing fine and what the blood pressure is. But I think, you know, following up on these patients is just so important, and diastolic function is a very nice way of looking at how the patients are doing. In this individual patient, we could not measure pulmonary pressure, but it's not necessary anymore. We have at least one parameter that shows us that filling pressures must be high, and it's clear that it needs diuretics. Of course, we can go on, and here are now the values, and you very nicely see that the E wave is, of course, more than double the size of the A wave, and you can look at the E to E prime with only 0.3, and that amounts to basically a filling pressure, which is, you know.
But maybe you should not do this, because that's not easy. Easy is the left side inflow pattern is restrictive. Okay. Stop it. Don't use E prime.
So I'm still caught in the old way of doing it. I guess you're correct. This you don't need. Okay, you could stop here. So that kind of makes it a little bit easier.
That's right.
Good, let me answer a few questions. Jali says, hi. Hi, Jali. How can we assess diastolic function in a patient with prosthetic mitral valve?
Yeah, it's not really possible. It's not really possible, and you have to face the problem and put it down in your report. There is no sufficient data.
I mean, you can, probably a problem to use the tissue Doppler values, but can you use the E and the A?
Also, this is a problem because the inflow velocity is increased and depends on the prosthesis you have, and so it's not really possible. And yeah, a lot of data, a lot of studies, and yeah, it seems that there is no robust parameter, let me put it that way, to say in every patient with prosthesis. So yeah, it's not that easy. What do you think?
Well, actually, to be honest, we usually did assess diastolic function with the E to A ratio, and even in patients with prosthetic valves. But I guess I agree. You have to be very cautious. What we don't use, obviously, is the tissue Doppler values. But I can understand your point very good, because you should not use it in mitral stenosis. And in theoretically, a prosthetic valve is, I would say, at least in the mitral position, kind of a.
There are some data for pulmonary vein flow patterns, and for the atrial reversal minus the A-wave duration seems to be the best. But all the pulmonary wave patterns, they are hard to acquire, and they are
Do you use it?
Rarely. It's not that feasible. We tried in our lab, and we started to use it in every patient, but obviously we are not that good, or not that good the study echocardiographies were. Also, no. Rarely.
To be honest, I haven't had such good results. We've tried to get good signals. It's been stated in the literature you can get good signals in 70%. I was not able to get it in that high percentage.
Well, we couldn't reproduce the good study reports. No, sorry, we tried.
Okay, so but again, that's what's stated in the guidelines, and it's possible. So Raluca asks, maybe a subclinical systolic dysfunction is actually a normal systolic function for the patient's age. Well, I agree that even even Speckle tracking values decrease over age, but I would not call it a normal function. If someone is healthy, we've had 80-year-olds who have basically normal Speckle tracking values, but I'm not aware of any guidelines or any publications that look at the age dependency of Speckle tracking, but maybe this would be a good point that I'm going to look into, and maybe in the Speckle tracking course I'm going to comment on that. In your experience, how often does diastolic dysfunction improve with therapy? In other words, by optimizing antihypertensive therapy. As an anesthetist in South Africa, elective surgery is often cancelled in these patients with the hope of improving diastolic function with therapy. But I don't think it improves much. What is your experience?
First of all, I'm surprised that there are cancelled operations.
Yeah, I would not understand why
that's unusual in Europe.
Yeah, I mean, I don't think there's an indication to really stop operation because patients have diastolic function, but I do also agree with your observation that very unlikely would you see a rapid change of diastolic function in hypertensive patients. If you in some patients, what you do see is if they're decompensated, if patients have hypertensive cardiomyopathy with overt or subclinical systolic dysfunction, and you give them diuretics, you can see the effect that maybe patient reverses from a restrictive pattern to, pseudonormal, or from a pseudonormal to a relaxation pattern. But in reality, I think if you want to have a long-standing effect, it would mean that you decrease the thickness of the septum, and that takes months, years to really come into effect. So I would be very skeptic as using this as a clear indicator. I mean, one thing that I would probably do in these patients is look at the BNP.
Yeah, that's a good way of it.
Okay, one more question. Alejandro asks, is there any value in measuring the tissue Doppler velocity pattern of the posterior wall in parasternal short axis view? In other words, an apical four-chamber view, if a four-chamber view is not easy to obtain. Can you do that? Tissue Doppler velocity pattern of the posterior wall in a parasternal short axis?
You can do it, but I wouldn't be sure what to do with the result, because I don't know. Data, I don't know, maybe you know a study.
Well, I think the problem is that the tissue Doppler is actually angle dependent. In other words, you can only measure the motion towards the transducer. If you have a short axis view, it will not really give you the motion of the angles towards the apex, but it'll give you kind of the motion towards the other ring. In other words, the getting smaller and larger of the ring. So that would probably not correlate with diastolic function. So I don't think this is feasible. That's the limitation of tissue Doppler.
It's a good point, especially the angle dependency. Don't forget it. Try to avoid big angles and so on. You get false measurements.
Okay. Okay, I think, I hope we were able to answer most of your questions. I know there might be many other questions out there. I promise that we will have more on diastolic function coming. If you think this is a very important topic for you and you don't have enough yet, let us know. You have the possibility of writing us mails, and you can do that obviously, and we will stick our heads together. The next step that we're planning now is we're planning a new lecture, a new chapter on diastolic dysfunction in our masterclass, where we account for the new guidelines, and where we also, of course, look at new ways that we think might be helpful in daily clinical practice, and maybe update some of the things which need to be updated. Well, I can only thank you so much for being with us. I must thank Martin for his experience that he's sharing with us, and I wish you a nice week and hope to see you soon.
Have a nice evening. Thanks.